looking at early intervention, if you have symptoms that are bothering you, going through all of that is really helpful early. So don't wait until you're on your hands and knees with symptoms and crawling in, or until your periods have stopped. Come in when you're symptomatic.
Hello and welcome to another episode of the HSE Talking Health and Wellbeing podcast. My name is Noreen Turley, and today we'll be talking about all things menopause. I am delighted to be joined by Dr. Caoimhe Hartley, who is a GP, and she's specialising in women's health and the menopause. And Dr. Hartley is also the clinical lead of the Complex Menopause Clinic in the Rotunda Hospital. I also have with me Dr. Cliona Murphy, Clinical Director of the National Women and Infants Health Programme in the HSE. And Cliona is also a consultant obstetrician gynaecologist. I just have to say that I am delighted to be doing this podcast because, just saying, I may be a lady of a certain age, and every conversation I have with my friends and my book club, my sisters, my mother, is about the menopause at the moment. And it is fantastic that we're discussing it. But I did find when I was trying to go into more detail preparing for this podcast, there is so much information, and it's really quite. I'm concerned that some of the information may not be a trusted source of information. So I think we should start at the beginning, if that's okay with you. And I just want to ask you, what is the menopause? It's as simple as that.
So the menopause generally is when the periods stop, But from a medical perspective, a woman is menopausal when it's been 12 months since her last period. So obviously the problem with that is you're looking backwards. So the symptoms of the menopause may start before then. So that is where the difficulty is, really. It's very clear when a woman is 52 and she's had a year with no periods that she is now in the menopause. Sometimes people ask, well, when does the menopause stop? And, it's really a time period in life. The menopause occurs and then it continues after that. And people think it's a defined, few months, etc. So it's not quite like that. And the difficulty is for some women, they will have maybe a few years of symptoms coming up to those 12 months. For others, they may not have that many symptoms. So it is very variable. But the medical definition, if you like, is, 12 months with no periods. But the lived experience of each woman can be quite different around that time. So the average age in Ireland is about 51. The average age in other countries can be slightly lower, it can be in some Asian countries, it can be 49. So there is variance among different cultures and countries.
So I think that causes a lot of confusion for people because there is no defined age. And Caoimhe, if I ask you then, why does the menopause happen?
Okay.
Why do we have to go through this?
Oh God, that's a good question. Why? It's so unfair, isn't it?
It is so unfair.
Well, it's part of reproductive evolution, I guess. And what we know is that through your reproductive years, so you start with puberty and then you start generally ovulating once a month on average, unless you're pregnant or on birth control pills or something like that. And when we get to perimenopause, which is the few years before your periods actually stop, and that's when we start to see hormonal change happen. And it's really characterized by large fluctuations in estrogen production. So our estrogen, when we get to our final period, our estrogen production from our ovaries stops. And that's what creates an awful lot of the symptoms that we hear women reporting at that point. But the few years before your period stop, that estrogen starts to really fluctuate. And at times you're actually overproducing estrogen, and that creates symptoms as well. But in the background, what's really happening within your ovaries is that you're not producing as many follicles at the beginning of each cycle. And that's part of normal ovarian aging for most women. And that loss of ovarian function, that's eventually what leads you to your final period. You're not ovulating anymore. It's the end of reproduction, natural reproduction, and the end of producing estrogen from your ovaries. And that's what creates menopause. Why it happens, I suppose, is more to do with, evolutionary biology and that kind of thing. I don't know, have you ever heard of the grandmother hypothesis, which is a theory?
Well, I'd love if you tell me.
So there's a theory that not reproducing naturally after a certain age allows an older generation to assist with a younger generation who are then having children. So it's kind of this tribal effect of protecting and helping with new babies and children. And that kind of leads, it's better for the overall, for society in general, if we have this kind of family effect in terms of raising kids and protecting a family unit, if you like. And from an evolutionary point of view, that was beneficial. And we see it in other animals. So they talk about like whales. God, we're really going a bit off-road here, right?
No, that's okay.
But I think it's really interesting. Yeah. So they're the only other animals we know of that actually live long past the cessation of natural reproduction. And you see that a similar kind of family unit happen and a similar assistance with raising young. So there's a theory that that's maybe from a biology point of view why it was beneficial and why it has stuck around.
Oh, well, thank you very much for that. I never knew anything about that.
There you go.
But menopause over the last couple of years, and maybe, like I say, I'm a lady of a certain age, so maybe I'm noticing it more, but I do think that we are speaking more openly about it and we are having more conversations about it. And do you think we should even start talking about it earlier in somebody, like, should it be in schools? Should it be in...
I do think so. I mean, I think the conversation is happening at the moment, but the conversation is often happening, among women and among women of a certain age. Yeah. Whereas, in fact, we all interact with families, partners, husbands, children. So often, I think the education in schools, focuses a little bit on, periods for girls and how not to get pregnant, etc. for both sexes. So maybe a little bit wider because their mums could be going through menopause, and it can cause you to be a little bit grouchier than usual, etc., and maybe less tolerant of things. So just an awareness of they might help tidy their rooms a bit better, So all of those things, the family unit and wider society, I think needs to be aware. Now, I think it's trickling out there, but initially, as we spoke earlier, it's a little bit more among the women themselves and book clubs, etc. But I think if we get a bit more comfortable talking about it in general, and not to, stigmatize it either. It's a phase. People are living and working through this. We shouldn't necessarily be making it into an illness. It is different for everybody. Some people do suffer significantly. Some just need some support going through it, but otherwise are, living very healthy and productive lives. And I think the other thing is, women's lives now are very, are different to grandmothers who may have been in the home more, may have had more restrictive lives, if you like. But women in their 50s now are, working, they're holding on responsible jobs, they're, doing a lot, and they want to continue doing a lot. They don't want to be leaving the workplace. And we do have evidence that a percentage of people will leave the workplace in their 50s, and some of that could be due to the the transition with menopausal symptoms, but with the right supports they could continue on. Otherwise, we're losing people who have a huge amount of value to institutions, to corporations, to small businesses, and that would be a shame. So I think normalizing talk and supporting people to get through those few years and to stay in the workforce until they want to leave would be hugely beneficial to society.
Yeah, absolutely. And we know the menopause is inevitable. So if we were to talk for all women, right, it's inevitable. Everybody has to go through it at some stage. If you want to talk about, and you spoke a little bit about perimenopause and the symptoms. Now, when I was preparing for this podcast, there were so many symptoms, and I don't want to frighten our listeners, but there are a lot of symptoms, and we all are familiar with, the hot flushes and maybe anxiety, but there are so many more. So maybe, if you wouldn't mind, Caoimhe, can you talk us through just a few? Because, like I say, I don't want to scare the listeners.
The rest of the podcast will be nothing but me reading out a list of symptoms.
Yeah.
So I think it's really important to start with that and say that although it's obviously excellent that we've seen, so much information and so much talk about this, the worry is that we terrify the living Jesus out of people when they get to their 30s and they're thinking, oh my God, this awful thing is looming ahead of me. It's not. And there's at least 20% of women whose periods will stop. That's their symptom. And other than that, they feel well. Also, not everybody gets the health changes. So not everybody going through menopause is going to get a heart attack in their 50s or 60s or get bone density loss to the point that they have osteoporosis.
Yeah.
It's not universal, it's individual. Other factors play into it, your genetics, your lifestyle, other, a bit of luck, maybe other things play into it. But there are 70 to 80% of women who will get other symptoms.
Yes.
And what's really interesting, I think, in the last decade is, and in particular in North America, they started to talk more about perimenopause than menopause. One of the frustrating things we find is that women will come in their mid-50s, their periods have stopped. And obviously we're more interested in the women who are having symptomatic or having symptoms that are impacting their quality of life. They're the women we really want to talk to and intervene with. And they come in saying, I've had symptoms for 10 years or 5 years.
Why do they wait so long?
A lack of information. That's on us, I think. And it's only like this change in the level of like the, menopause being in the zeitgeist, that has only happened in the last 5 or 6 years. So it's not women's fault, it's our fault. But thankfully, look, we're sitting here today, we're doing this. This is all part of why that worm is turning slowly, But it's interesting because we've kind of growing evidence that intervening in perimenopause for women who are symptomatic can be helpful. And even from a health point of view. So I think it's helpful to split it into two things. There's symptoms that women experience and then there's long-term health changes. And they're two different things. The symptoms, like you said, as long as your arm, because you've estrogen receptors everywhere pretty much. But if you were to pick out the ones that we hear the most about, one is mood and emotional symptoms. And lots of women experience anxiety, for example, for the first time in their life as they go through perimenopause in particular. And it's because they're strapped into a bit of a hormonal roller coaster. So their brain may have tolerated fluctuations in estrogen and progesterone previously, but those fluctuations have become more than little bumps. Now they're kind of a big up and down roller coaster effect. And that creates changes in mood, changes in irritability and anxiety. Again, not for everyone, but for a significant percentage. The other thing that we hear commonly is cognitive changes. And that's an area that we're becoming increasingly interested in, that you're seeing more research happening in, which is, welcomed. And it's biological. It isn't in your head. It isn't just a feeling of I've gone a bit sort of baby brainish, like, I'm a bit muzzy in my head. It's genuine biology. You can see changes on PET scans of people's brains that relate to their serum estradiol, their estrogen levels. So we know there's something happening. And commonly that manifests as verbal fluency. So being able to find the right word, think of someone's name, that kind of thing, and short-term memory. And that then has a knock-on impact on confidence. And if you're in the workplace, as Cliona has mentioned, this is why we see women exit the workplace. It's not just hot flushes and night sweats, which I should also mention. They're common. But I would hear more often, it's the brain fog affects me more. I live with the hot flushes. I cannot live with this feeling that my brain is fuzzy. It's not functioning like it used to. Some physical symptoms too, obviously hot flushes and night sweats, but joint aches and pains are the other quite common thing. And then you have genitourinary symptoms of menopause. So things like bladder symptoms, like needing to pee maybe a bit more frequently, increased incontinence, increased urinary tract infections. Vulvovaginal dryness, painful sex. So they're all the kind of genitourinary symptoms and everything in between, and lots of other weird and wonderful.
So I think, Cliona, you wanted to come in there on the whole area of symptoms.
Yeah, so I mean, as Caoimhe said, there's quite a lot of symptoms, but not everybody will get all of the symptoms. So that's important to point out. It's a mixed bag. And some people will recognise, hot flushes, night sweats. Yes, that's menopause. I know what that's about. But not necessarily realise that having had urinary tract infections is potentially a symptom as well. One of the things I see quite frequently that people don't link up would be sleep problems. So typically complaint of waking up at 3 or 4 in the morning and then not being able to get back to sleep till 5 or 6, and obviously that's a huge knock-on effect on life and work and everything. And then adding to any other symptoms, as we spoke about the brain fog, anybody who's missing a few hours sleep isn't, going to be feeling great. So I think it's important to also explain that that is a physical symptom. It's not something that can necessarily prevent. There are things you can do to help your sleep. So sleep before 12 o'clock at night is important. So getting to bed a bit earlier, making sure that you don't have screen time, avoiding tea and coffee, all of those will help. But just an explanation to people that this is actually part of the menopause, that you're not being dramatic about this, and this is a real and significant symptom is helpful. And people, do find that reassuring that they're not the only person going through that, So, but again, the wider audience of the family work colleagues and,
of course,
if they know somebody's been awake for a couple of hours during the night, would have a bit of sympathy, so.
And it is all of those symptoms that people do think with the brain fog, like, what is wrong with me? Why can't I cope with this situation? They may be of an age that the kids are, if they've had children, that their children are maybe now 12, 13, and they're just about getting settled with the kids are getting more independent, and all of a sudden they have these anxieties and these sleepless nights, and it just seems, if they don't recognize it, they're probably thinking, well, everybody else can cope and why can't I? But maybe behind it all, everybody else is not necessarily coping either. So one of the other symptoms that I've heard people mention is headaches, and that's really difficult for people as well, isn't it?
Yeah, and often it's not something that they recognize. It's put down to stress, it's put down to work, it's put down to, other things going on. So, and it can happen before the actual menopause, so in the perimenopause or the few months coming up to it. But it can happen for a subset of people that they do get headaches associated with those estrogen fluctuations, and that, sometimes then, when things are, addressed, if you like, and they're on HRT, that things improve, and you go, oh, that was all to do with menopause. I can't believe it,
Yeah.
Now, that's slightly different to somebody who has maybe had a history of migraine, that's all their lives, so they may be a different cohort, but those with new onset headaches and migraines, potentially it can be all part of the menopausal subset. And, so it is important to talk to their doctor, because they may think they're not suitable for HRT. And in fact, it could be just the thing that they need, so.
Absolutely.
So women with a history of migraines absolutely can take hormone therapy. We do try and use only the transdermal products for their estrogen. So this is your patch, your gel or spray. We try and avoid using oral estrogen, the tablet form, because of that small increased risk of blood clotting and stroke. But if you have a history of migraines, you can take HRT, is the bottom line.
I think that's a really important message. Thanks for that. So, their first call would be to go to your GP.
Yep.
Yeah.
I think it's a good place to start. Yeah. And I think sitting down and having that conversation is important if you have symptoms that are bothering you. But I suppose we would lean towards saying, look, if you're still having periods, don't feel, well, then I can't go and talk to someone. And I think that's maybe an antiquated approach that we still see trickle in a little, that people will say, I'm still having periods, that therefore I'm not menopausal and I won't. There's no legitimate reason for me to go and talk to someone, and sure, I can't be treated anyway because I'm still having periods. So that's not true. And getting that message across is really important, even from a health perspective. Looking at early intervention for things like bone density, and that doesn't mean HRT necessarily. It means educating and having a discussion early about planning for your long-term health before you get to menopause is really important. It's opportunistic on our part.
Yeah.
We like getting women in their 40s and saying, okay, we know that this change that is coming and the ultimate loss of estrogen is going to have an impact on your long-term health. So let's have a chat about that. Or, have you risk factors? Is there a family history for cardiovascular disease or breast cancer or bone density loss and osteoporosis? Do you smoke? What's your blood pressure? Have you had your cholesterol checked? Going through all of that is really helpful early. So don't wait until you're on your hands and knees with symptoms and crawling in, or until your periods have stopped. Come in when you're symptomatic.
Caoimhe, just talking about that and people not coming in at an earlier stage, do you think it's part of it because people don't want to admit they're getting older, that they have the menopause, that they're starting the menopause, and that we're an ageist society, that we just don't want to get old and we don't want to admit that we're getting old? What do you think about that, Cliona?
I think there's two things. Yeah, you might be onto something there, but also I think women are very busy. Okay, women we know they do the majority still of the domestic work. They do the majority of child rearing. So for many people, the 40s is a very busy time, and we know for various reasons people have been starting families a little bit later. So there's an awful lot of picking, dropping, looking after everybody else, I would say, and not actually having the time to prioritize to go for themselves. So I think that's definitely a bit of it. I think, as Caoimhe said, it is maybe a time to look at things in a positive. This is now a time to get a once over look at everything, not just the menopausal symptoms, but, where am I with, general risk factors, etc., and then look at things going forward. The other way to frame the menopause is there's a bit of a positive to it. I mean, when we're looking back again, with the evolutionary side of things, now it's, once you do get to the menopause, the risk of, an unwanted pregnancy or something like that is gone. So there can be a certain freedom to that.
Yeah, of course.
And certainly in some cultures, menopause is kind of venerated, and, women of menopausal age have a certain stature in that, So I think, can be somewhat liberating. And if people look at it through that lens, then we can turn that without, all the doom and gloom about the symptoms, but also listen, things are changing now, and maybe it's time for a bit of focus on women's health and going forward. So I think we've a bit to go there, but I don't think we should be shaming people or giving out that, that they haven't come forward. Some of it is lack of recognition. It's only now that there really is enough information out there. So, whatever time people present is fine. If somebody comes to me and say, "Oh, I should have come a year or two ago," I'm saying, "But you're here now."
Exactly.
So,
exactly.
Let's go from there and to look at it positive and talk through it. So I think we can kind of frame it in a more positive way.
No, I think that's really good. I think that's really good, Cliona, because it does sound, a lot of doom and gloom. I just wanted to go back to the bone health then. When we're talking about bone health, are we talking about taking vitamin D, or what would be a good thing for people to do?
You look at basics, so remove things that are going to exacerbate bone density loss. So we see a rate of about 2% per year bone density loss in the first 5 years after your period stop. Now that's average. And then it kind of slows down after that. So there's a fairly dramatic sort of, period of bone density loss after the period stop.
Yeah.
So what you want to do is look at risk factors. Smoking is the obvious one, and smoking is going to make bone density loss more dramatic, reduces down your ability to get to your peak bone density in your late 20s, early 30s. So reducing, but ideally stopping smoking if you can, reducing caffeine. And then we talk to everyone about increasing their weight-bearing exercise, increasing their vitamin D intake for most women in Ireland. And so that's really from Halloween to Paddy's Day is what we'd recommend, that most women should be taking a vitamin D supplement over the counter from your pharmacy. Keep it simple, and plenty of dietary calcium. You're aiming for about 1,000 milligrams a day, which is about 3 to 4 servings of something rich in calcium, which
and again, you can get that over, or you can just buy it over the pharmacy.
And it doesn't need to be the most expensive brand. There's an awful lot of branding and, expensive vitamin supplements.
There's loads.
So, you can, the sky's the limit with regard to what you pay. But actually, if it says vitamin D and it's just vitamin D on the box and it's, €5, that is perfectly fine.
That's perfectly fine.
Now, what I would say is it doesn't work well in the cupboard. As my husband has said to me,
You have to take it.
Yeah, he said, that's not working that well up there now, So you have to take it, and also think of, calcium in your diet. So yogurts, milk and that. And those who maybe for whatever reason don't take that in the diet need to be aware of that maybe from a slightly earlier age of their, vitamin D and calcium in the diet. So just the calcium, they both work together. So it's important to keep that up.
I'm just thinking, I've got 3 daughters, and one of the things is I need to talk to my daughters about the menopause. Just not today or anything, but, because maybe if mothers start talking to their daughters a little bit more and take some of the fear out of it and explain, like you said, some of the positives about it as well, then at an earlier age that they're ready for it,
And there has been research looking at cultural differences with menopause. And some of that research would show that in societies and cultures where we're more embracing of aging, and as Cliona pointed out, where there's kind of a stature associated with it, or there's positives associated with aging in general, that women tend to be less symptomatic going through their menopausal years.
That's unbelievable, really.
Yeah.
And I'm sure, I'm just saying I'm not sure, but I'm just wondering, would that be more so around things like mental and emotional well-being?
Yeah, actually,
I'm going to demand that now a little bit more respect or whatever.
Absolutely, yeah. But it is reframing things and not seeing everything about aging, if you're female, as a negative. And I think some of that empowerment that we're doing with discussing things like this helps towards that. It helps women feel less, hopefully less frightened, not more frightened of what's coming, and empowers them to know, look, if I am symptomatic, I don't just have to put up with it. And if I'm not symptomatic, well then fantastic, and I focus on my long-term health. Not blaming women for being symptomatic, is really important. Yeah.
I know. Did you want to come in? Go in
there
there.
are some symptoms, that can occur maybe 3 or 4 years down. So you may get through what you feel the menopause is without the hot flushes and night sweats and think, oh, I've done well, lucky enough. But there can be some that creep up then later, sometimes with recurrent urinary tract infections, sometimes vaginal dryness and difficulties then with sex.
Yeah.
And because they haven't had the hot flushes and night sweats, again, the link isn't made that this is actually due to, lack of estrogen in the body.
Yeah.
And so those women, I find, can sometimes delay asking for help because they might find it a bit embarrassing, and also they find those symptoms a bit minor and they don't know how to categorize them as such. So, but there is help available for those type of symptoms. So it is important. They are a subset of menopausal symptoms and they deserve equal recognition in that,
And what kind of treatments then, when you're talking about sexual health for women, then what kind of treatments during menopause would be?
Well, for those particular ones, sometimes, if a woman hasn't needed your regular HRT, if you like, and Caoimhe may talk about those in a while, but, or for people who don't want to be on the patches and things, but they may have very specific urinary tract or vaginal symptoms. Sometimes just some local estrogen can be life-changing for them, and some advice about lubrication, etc. So the sex life isn't completely down the tubes, which, unfortunately, some people think, oh, that's it now. That's, that's over there. And, you have to say, no, you're young yet. There's no reason for that to stop if you don't wish it to. So it really is important that people are aware that they can present with those symptoms and ask for help.
And you see, that might be a symptom that people just are embarrassed.
Oh,
or
absolutely.
They just think like, that's over there. That's, that's gone now for me.
And that can, that can have a real effect on confidence and relationships and all of that. So it is important to say that there is help out there.
Yeah. And just, I suppose, talking about HRT, maybe, Caoimhe, do you want to go through the options of that? Because it sounds quite complicated, or there are lots of options, but it's not as straightforward as just to having a patch or a bit of gel or something. It is quite complex, isn't it?
It can be. Yeah, it can be. I mean, hormone therapy has been around a really long time and has evolved over that time, thankfully. So, the kind of backbone, the foundation of HRT, or MHT, as we're starting to technically call it. Yeah, menopausal hormone therapy. So it's estrogen. That's what we're providing most women. In perimenopause, for someone who is experiencing symptoms, the reason we give HRT, or the reason we give estrogen, which it sounds kind of counterproductive, because we open with telling them, oh, look, you're often making too much estrogen. And then I'm going to treat that by giving you more estrogen. Sounds really ridiculous. But the basis of that is that we're trying to calm down what is a kind of chaotic hormonal fluctuations, hormonal fluctuations in the background. And sometimes providing a little bit of consistent baseline of estrogen seems to have this effect of making everything a little bit calmer and settles some of those fluctuations down, and symptoms improve. They don't resolve for everybody, but they improve. That's what we're aiming for. And in women who have stopped having periods, or they've had their ovaries removed, for example, estrogen provides them, I suppose, some relief from symptoms. We want to get them above a threshold where their symptoms are better and where we don't see as much of an impact on things like bone density or heart health, for example. So that's the estrogen. All of your good stuff is coming from estrogen. We have to give you a second hormone called progestogen if you still have your womb, or if you have a history of endometriosis, for example, even if you've had a hysterectomy. So what we're trying to do with the progestogen is protect the endometrial cells, the womb cells, from the stimulating effect of estrogen, because we know that women who take estrogen on its own, if they still have a womb, have quite a marked increased risk of womb cancer. So the progestogen protects you or reduces that risk. That's called combination HRT, because it's a combination of the two hormones. And then there's various ways. So where it gets complicated is how we deliver those hormones to you. So some women will take estrogen as a tablet, which is absolutely fine. And they're really convenient. Obviously much easier to take a tablet than have to lather yourself in gel or apply patches or whatever it might be. So tablets are often more straightforward, and they're often something that people are used to. They might have been on the pill or something in the past. So the downside of the tablets is that there's a small increased risk of blood clotting and stroke. And certainly for women, as they go past 50, we see this small baseline increase of your risk going up anyway with aging. We don't want to add to that. women with migraines, women who smoke, women who have a history of blood clotting and so on. These are women we really want to avoid oral estrogen for, and that's where your patches and your gels and your spray come in. So there's 3 products. There's patches, there's a gel, and there's a spray. They all deliver estrogen, but they're all delivering the same estrogen. So whether you end up on a gel or a patch, totally individual. So I don't have a preference. I'm always asked, like, which is best? It's whichever suits you is best. In terms of risk profile, all that kind of thing, they're all exactly the same.
So it is a balancing act, though, between the estrogen and the progesterone.
Kind of. The progestogen, we have
progestogen, sorry. Yeah.
So there's different types of progestogen. We commonly use micronized progesterone, which is basically a kind of what they call a body. I hate the term body identical, but technically that's what.
Yeah, that's a term that I've been hearing a lot lately, this body identical. Why do you not like it?
Because I feel it's a bit buzzwordy, and I think women, and sometimes they'll read about it as if it's completely safe and carries no risk, which isn't true either. So it's just something that's mimicking what your ovaries produce. When your ovaries produce progestogen, they make progesterone, and we're giving you progesterone. So it's a type of progestogen, like different brands of washing powder. So there's different ways of delivering that progestogen to you. There's progesterone, which is often a capsule that you take by mouth or can be inserted vaginally. There's the Mirena coil, which has loads of benefits as well. And that will provide protection for your womb for 5 years as part of HRT. There's other progestogen tablets as well. And so we've loads of different options. And that's where it becomes complicated. It's this kind of working out what combination.
Yeah.
We have a minimum amount of progestogen that we have to provide your womb in order to reduce that risk. So you can't go below a certain level with the progestogen, or we're not giving you that protection. But as your estrogen goes up, if we're giving you more and more and more estrogen, which we shouldn't, but for some women, they require higher doses. We have to match that with a slightly higher dose of progestogen, again, just to provide that basic protection for the lining of the womb.
Okay, so it is quite complicated. I'm glad that you're well qualified in prescribing all of that, because it is quite complicated. But like you keep saying, there are benefits to a lot of these things. Is that there's other benefits to the hormones as well?
Yeah, I mean, there's a small reduction in cardiovascular risk.
Okay.
It's not dramatic. So if you're someone who has no symptoms, you've normal bone density, you shouldn't go on HRT just to reduce your cardiovascular risk. So its principal action is to improve your symptoms. That's what we're using it for. Now, in women under 60 who have a diagnosis of osteoporosis, we can use HRT to treat that osteoporosis. Outside of that, it's either that you're very symptomatic and we're trying to treat that, or women who are under the age of 45 who have stopped having periods or have had their ovaries removed.
Okay.
They get more, they get considerably more benefit than risk with HRT.
Yeah, and I mean, I know some of these sound like complex cases that you look after in the Complex Menopause Clinic, so maybe we'll talk about that a little bit later. But Cliona, did you want to come in there with any of that?
Yeah, as Caoimhe said, it's really important for those having menopause at a younger age than expected. So if we say the average age is 51, if you are under the age of 45, that's younger than your peers. And then there are a small proportion of people under the age of 40, where they're premature ovarian failure, and there can be reasons for that, genetic reasons. They're in a different category, and we really would recommend HRT for those because, there's a gap of about 10 years where they're losing out. There are some people who will present maybe at the age of 60 and just sort of say, I think I should be on HRT because I've heard so much about it, and should I be on it? And the answer is, if they're not having symptoms, really, we wouldn't be recommending it at that stage, because probably the risks are higher than the benefits at that point.
Yes.
So it really is, we're down to kind of individualized care plans for people. So what your friend is getting may not be what you get.
Yes.
So really, not to be comparing notes necessarily. And what we spoke there about the different ways of administering the HRT. So again, that could be individualized, what one person, what suits one person and their lifestyle may not be the same for somebody else, And I suppose the principle is we want to get the, lowest amount of estrogen that is solving the symptoms.
Yes, it's effective.
And then it is really important to explain to people that, they need the estrogen and the progesterone, because the estrogen is, what in pregnancy makes your hair good and that shine in people's faces. But the progesterone can sometimes, drop your mood a little bit. So often women find when they're on the progesterone, they'd like to be doing without the progesterone, but unfortunately it doesn't quite work like that. So particularly for the tablets, it is important that they take the progesterone part of it. But then if for whatever reason there's been a hysterectomy, then it's estrogen only is needed. So that can simplify the process there.
Yeah. And I just think when we mention HRT, or that we can't go past it without mentioning the fears that people still have and women still have about taking it. And that study that was done all those years ago, and we're still trying to get rid of that fear and the explanation around that. So I'm not sure.
Okay.
Do you want to maybe just deal with that, Caoimhe, just as simply as you can, because I know it's complex.
Okay. So you have to look at both sides of the fence. There's benefits, as we've mentioned. So HRT, fantastic, estrogen, fantastic at reducing bone density loss. And again, early intervention, like there's quite a bit of research showing that, your estradiol levels are kind of maintained in perimenopause at the expense of another hormone called FSH, which goes up. It's a hormone that your brain releases to control your ovaries or influence your ovaries. And with that rise in FSH, that's where we start to see the bone density loss happen. So that's before your periods have stopped. And women who are really high risk of osteoporosis or who have osteoporosis, estrogen is a really good way of preventing that bone density loss really at any point. So my point being, I suppose, that it starts early is the point, So we know it protects bone. The small reduction in cardiovascular risk has quite a protective effect on our blood vessels and our brain, which is good. I get asked a lot about the dementia impact, which is really controversial. There may be a window of time where we may be able to intervene and slightly reduce dementia risk in a small subset of women with genetic predisposition for Alzheimer's. Like it gets very kind of niche.
Yes.
So it isn't an across the board, everyone go on HRT to reduce your dementia risk. That doesn't exist. And actually older women get a small increased risk of dementia if they start HRT beyond 10 years from their menopause. So it's really complicated, and we do see a reduction in the diagnosis of type 2 diabetes, and even in colon cancer, colorectal cancer seems to be reduced as well. None of these are reasons on their own to go on HRT, but just, that's all good. And actually, if you look at the Women's Health Initiative, that study that you alluded to there a second ago, the big study that was done in the 90s, they showed a reduction in all-cause mortality. So dying for any reason at all was reduced in the women who had taken HRT. So we know that there is positive health impact.
Yeah.
Okay, other side of the fence then, we see an increased risk of different things. And the one that most people think of is breast cancer. So that's what I get asked about the most.
Yeah, that seems to be, and even now people are very unsure.
Which is reasonable. And one of the problems is that breast cancer is common. And we all know women who have been diagnosed with breast cancer, and it is terrifying. So if I say anything carries a risk of breast cancer, people are going to be scared. That's, completely rational. The Women's Health Initiative showed an increased risk of breast cancer, and other studies since have also shown an increased risk of breast cancer with combination HRT.
Okay.
So the women who take estrogen on its own, who've had a hysterectomy, may not have the same increased risk. Now, it may not be zero risk, but it is lower. So we're less concerned with women on estrogen on its own. In fact, the Women's Health Initiative showed a small reduction in breast cancer risk, although that hasn't been replicated in studies since.
Okay.
So the truth is probably that it's fairly neutral and may carry a very small but not hugely statistically significant risk of breast cancer. The women who take combination HRT, so your estrogen and progestin, and that's the majority of women that we would see, they do get a small increased risk of breast cancer over the age of 50. So the numbers that we would tend to use would be that we would see about 3 to 4 additional breast cancers per 1,000 women after 5 years of HRT.
Okay.
And the longer you are on it influences the breast cancer risk. So the duration of use. If you're someone who's on HRT for 20 years, because you're getting benefit from it, there is you're taking on more breast cancer risk than the person who takes it for 5 years. Which doesn't mean we can, knock on your door at the 5-year mark, wrestle it from your hands and leave.
But you probably would have to wrestle it from a lot of people's hands.
But that's important too.
Yeah.
So it's all about informed decision making and shared decision making. And there's also an increased risk of side effects. So this is why we're not just willy-nilly throwing everyone in HRT.
Absolutely.
Because first of all, there's an expense. It's a medication. You have to factor that in. It's a bit of a faff sometimes, applying my gel and taking my capsule and doing all of that. So it's an added complication to your day if you're not getting huge benefit from it. But the biggest thing we'd see is bleeding. Cliona will attest to this, I feel, because it's often on the lap of the gynaecologist that so a lot of women get unscheduled bleeding. So they'll take HRT and they might go back to, we kind of wake up their endometrium, the lining of the womb, and that causes some frustrating, irritating breakthrough bleeding that occasionally needs to be investigated. And so you're kind of going down that path unnecessarily, like it's all due to being on HRT.
Yeah.
So, there are downsides as well as upsides. Most women, for the first 5 years of use, over the age of 50 will get more health benefit than risk, though, and that's really important to know.
And just talking about the breakthrough bleeding, then, do you want to talk around that, or what people should look out for?
So
when should people come to get it investigated?
So I suppose to look at in the years coming up to the menopause, for some people, their periods get a little scantier. They might miss a month, here and there. But for a lot of people, they get heavy bleeding. And so you have a problem where they're, spending 7-10 days, with heavy bleeding. And that's a real nuisance. And that is something we see commonly. Again, there is help for that. So you see some people, some women struggling through it, whereas there is help for it. And some simple things like, medication or the merino coil can help with that. So it is important. It's certainly really important where the periods get chaotic and so they're not regular.
Yeah.
So when they're not regular, you really need to be seen, and particularly, when they get heavy and unpredictable, that's a really important point. And then, if the menopause comes, it can be a relief, and I see women sometimes they're 53 and they're like, when will it start? Because,
so this can stop.
And so it can be a relief to people. But for some going on the HRT, then the periods come back and that's not so great, or they can be troublesome, unpredictable again. So, and then there's a slight worry that, does this mean there's something underlying that? Is it, you have to discern, is it actually due to just breakthrough bleeding on the HRT, or usually there would need to be a scan to check that the lining of the womb hasn't got too thick. And if it's above a certain thickness, then we have to do more investigation. So that's another kind of day's work in that, and another layer of worry. So in some situations, that symptoms maybe weren't significant in the first place, and the decision might be made, look, I'd prefer not to continue on this HRT anyway. Or, there's a different type of HRT used, but the important thing is to make sure there's nothing worrying underneath it. And the women I would be concerned about that have maybe an increased risk of something worrying, predisposing to womb cancer, or a precursor to that would be women of a higher weight where there's a family history, and maybe those who haven't had any children. They're what we call risk factors for extra estrogen in your lifetime. And then if there is abnormal bleeding in the background of HRT, they're people we do want to check out, if you like. So,
you see, what I'm hearing from both of you all the time is, come to get treatment, come for help, don't just leave things. So would you say in that case, if somebody was having significant bleeding,
absolutely, absolutely,
get it checked out.
You don't ignore. And just to go back to what we were talking about, the breast cancer risk as well, and again to put it in context, what sometimes is forgotten is that there are other risk factors that are all around us, and that includes alcohol, and our country would have quite a high increase in alcohol. And I suppose in the last few years, we've noticed an increased consumption among women. So that's there in the background. And also weight as well can be a risk factor. So just putting it in context, that sometimes the breast cancer risk is just, well, that's the only thing that's giving you breast cancer risk.
But there are lots of other.
And, there's an opportunity as well for modifiable risk factors for all types of things. So being a healthy weight, getting exercise, all of those things are really important heading into menopause, and with your bone health, not just relying on the benefits or other of the HRT, look at the other
things that you can do.
Yes. And one of the complaints we would see a lot is because of the estrogen changes, there is a tendency to put on weight, the bit of tummy spread, and that can really be hard. But again, rather than accepting that, and look, we all change as we get older. Nobody is going to look like they were when they were 18. But again, to, sort of say, okay, well, that is life to one extent, but also you can embrace it and say, well, I'm going to get a bit fitter and, you know, feel good on myself. So there are definitely things that can be done.
That you can take control of yourself and make some changes to your lifestyle.
And sort of have a positive mindset into it, that, you know, not just going to sort of rely on just accepting everything is doom and gloom, as we said.
I know, that's really
weight
true.
comes up an awful lot in consultations, I find, understandably. Goes
We're
back
a weightist society and an ageist society.
I was just going to say, we talked about ageism, but you know, women are petrified of weight gain, and most of the research would suggest we actually gain the same amount of weight as men through the same age category. So from 45 to 65, most women will gain about 1 to 2 pounds per year on average, but so will men. And the big difference
why
is
do they get away with it?
Because we change shape.
So
we change the way we distribute that weight, whereas men do not. So this is where that central weight gain across your tummy happens. It kind of exacerbates a lot of the kind of frustration with, like, I'm waking up and it's not my body. This isn't my body. And interesting, it's happening because of biology and genetics. It's not happening because you've changed your lifestyle or you're doing something wrong. Now, it can be exacerbated by low mood and poor sleep. We know there's changes in leptin and ghrelin and these appetite hormones, with other confounding factors with, like, poor sleep, for example, which is so common, as Cliona mentioned, through menopause. And managing them is kind of step number one. So it's not just about eating less and moving more, because that actually doesn't do anything for your weight gain. You know, addressing your poor sleep, addressing mood factors if they're there, looking at those issues, joint aches and pains that are preventing you from going out and going for a walk or doing that kind of thing. They're step one. Talking to someone about nutrition, making sure that you're well informed, is kind of step number two. Not blaming yourself is probably the most important step. And, like, weight is obviously hugely genetic. And I think reaching out for help if you want it is really important too.
And I suppose then, just on that, because we're drawing to a close shortly, but where do people go for help with all of these things? Where would you advise, or what would you say to them?
Well, I would say with symptoms, we've said first step is your GP, you know, so they'll know you potentially because you've been attending through your life. They'll have a good overall kind of view of the health symptoms. And then for some people, they will need to go further. As we said, there are complex menopause clinics. They're really for people who maybe have medical issues that it's not as simple for the GP to advise. So there are some good resources out there, and hopefully this will be one. But there are some good books out there. Dr. Deirdre Lundy has written a book. I read a book by Dr. Jen Gunter that I felt was really good. However, there aren't a huge number in the bookshop. There's probably
now. There's an opening there for you to write a book, ladies.
About GAA, or, you know, there's an awful lot more of those kind of topics there. But there are some nice ones there. And I think they're useful to read because you can identify with some of the symptoms and say, look, all of these, you know, high profile women have had these symptoms. So that can be helpful to people, you know. So I think there's a bit about, you know, getting the information, and then if you've symptoms, asking your GP for advice. And then for some people, they will need kind of to go to a specialist clinic, but not all. And then for some, certainly with regard to kind of bleeding issues, it might be that they go to see a gynaecologist referred by their GP, you know, that there's a particular issue there. So that's the summary.
That's great, Cliona. And so, Caoimhe, you've set up the Complex Menopause Clinic, so I really want to talk to you about that because, like you say, you're going hell for leather with it and you're really trying to help women.
Yeah, so we're hoping there's 6 complex clinics being set up around the country that are hospital-based, run by specialists like myself who have an interest in this. And the clinic in the Rotunda was established in October 2022, and we're flying it, which is great. We're GP referrals only, so you attend your GP and then they might send a referral directly into us. We're increasing to 2 days a week from next week.
Fantastic. Congratulations.
So that's exciting, to work through the enormous waiting list that we have.
Can I just stop you there? It was amazing when I spoke to you before the podcast because you said you love your job.
I do
and
love
it's
my job.
so nice to hear somebody saying that. And you can hear it in your voice. And both of you can hear it in your voices when you're talking about it. Like that you obviously feel like you're doing something really worthwhile. So sorry for interrupting.
Yeah,
you. Back to your clinics.
But I do,
2 days a week.
I do love my job, actually.
Yeah.
And I think that's, you know, I don't think that's universal, and I feel really privileged to love my job and love the people that I work with. And there's days I drag myself in because I haven't slept and I have small kids and I have 2 dogs there, or a nightmare and all the way. But then when I'm in, and you sit down and you start talking to people, you remember that like, it's actually really interesting. And I get asked a lot about like, I kind of do the same thing over and over again. And it's interesting because every person sitting in front of you, I mean, I know it's a cliche, but they are completely individual and every story is different. And it is such a privilege to be let in the door into someone's life story, and to help them. So I do love my job. What was the question? You asked me
just saying, and the complex clinic and the type of people that come to you, and not everybody can go to the complex clinic because, as we've said, it doesn't have to be managed in a complex clinic.
No, we want to help people who can't be managed at a community level with their GP. So that's where our expertise is. So as Cliona mentioned, women with maybe a complex medical history, a history of something like breast cancer or a hormone-dependent cancer, women who've had blood clots, women who have struggled to find a HRT that really suits them and their GP is not sure where to go next. They're women that we should see. The other kind of exciting developments, we've recently rebooted the Menopause Society of Ireland, so that's really exciting. So we're hoping to roll that out over the next year. We'll be having an educational meeting in September.
So what's that now? What is the
it's aimed at healthcare professionals. So medics, doctors, allied healthcare professionals that are in this sphere. And myself and Dr. Claire Cromwell, who is based in Cork, are the current chairs. So that's exciting. And then we're hoping ultimately that we'll have a patient arm of this society. So in terms of resources, the Women's Health Concern, which is the patient arm of the British Menopause Society, is excellent and something that women could look up online. But hopefully within a year or two, we'll have an Irish equivalent.
Oh, fantastic. And so it's GP referral, it's not self-referral to the Complex Menopause Clinic.
Yeah.
And that's understandable.
Well, I suppose we have to have some sort of guardrails on it because otherwise we wouldn't be able to see anyone. We'd be so backlogged. So,
and that's only set up since 2022.
The clinic in the Rotunda was the second one. The clinic in Holles Street, run by the fabulous Dr. Deirdre Lundy and Dr. Nicola Cochran, that was the first one. Then we were shortly after that, and then there are 4 more clinics across the country. Yeah,
that's fantastic. That there's so much help out there. Did you want to come in there?
Yeah. So I suppose a shout out to the Department of Health and the Women's Health Task Force, where all that kind of came from really was listening to women and women saying we need more help with regards to the menopause, and actually the Department of Health listened. And so I work with NWIP, the National Women's and Infants Programme, so we were involved then when trying to get funding for these clinics. So I think in Ireland, there's an awful lot, that we can do better. But I think it's to acknowledge when we are heading the right direction.
It's great. Yeah. And there are steps. And even with we did a podcast on the fertility hubs. And so women's health is, and we are making progress. And I think sometimes there's so much work going on in the background and it takes a long time to get to this stage.
And it's just that it is evolving. So, some of those clinics have started before others. There's Cork and there's a hub in Nina for menopause. And, so it is, I suppose, to get equity of access across the country is really important to us in NWIP, to get information out there and then to have the resources in place. But, there's a big team of people behind that and I see a real cohesion in what the Department of Health are trying to do, what the HSE are trying to do, and really trying to put women's health on the agenda and actually following through on that, which is good. So we just need to make sure it's kept on the agenda for the next few years.
I know. Cliona, that sounds amazing though. It is good to hear so much positive news. And Caoimhe, you were saying that you have some information on the website that people can access?
On the Rotunda website itself, we have now, there's a tab, I think, that you click for the menopause service and it will give you information about the clinic, how to be referred, how your GP can refer you, what happens when you come to the clinic, who the team is.
Perfect.
There's a rather embarrassing photo of all of us, etc. Yeah, there's lots of information there people can check out.
Great. And I'm sure if people go to hse.ie as well, there'll be a link from there to the clinics as well, which is great. So I have loads more questions, but I think we're going to have a second episode, ladies. Part 2 for sure, because I have lots of other friends and questions that I need to ask you all. But for the moment, I'd just like to say to our listeners that if anybody would like to get in touch with us about the podcast, please send us an email at www.healthandwellbeing.communications@hse.ie. I'd like to really thank both of you for bringing so much energy into the room today and being so positive about all of this and explaining to people that there is help out there. And I think it's just phenomenal the amount of help that there is. But if you just need and just tap into it and not to be afraid to go and get help and not be suffering in silence. You don't have to be a martyr to the cause. And for women, not to be afraid and embrace getting older, maybe. As always, we ask you, please share this episode with a colleague or friend who you may think would benefit from it or who may be interested in this topic. And thank you very much for listening.